I'm Matt Hopcraft, and I'm presenting this evident retrospective case series research project on dental practice-acquired SARS-CoV-2 in Victoria from 2020 to 2021. The data used for this presentation was collected as part of Evident Project 31, and the information in this presentation is my opinion. You might recall seeing something like this at the outset of the pandemic, a risk cluster chart of professions and jobs showing which professions were most likely to be at risk of contracting SARS-CoV-2. There was a general perception that dentistry was one of the most high-risk professions, and you can see us sitting up there at the top right-hand corner of that chart, related to physical proximity, being close to people, and exposure to the virus. And from first principles, it kind of makes sense. We're talking about a respiratory virus, and we work and live in people's mouths. We generate aerosols for a living. So working with a respiratory disease that infects the oropharynx in close proximity to that made us consider that dentistry was a really high-risk profession. And partly that was the perception that aerosols generated during dental procedures contain the virus and would be a source of transmission. And certainly some of the early studies showed indeed the virus was present in saliva, and also the patients were at their most infectious immediately prior to symptoms, which is a little bit different from a lot of other respiratory illnesses where you became symptomatic and then your infectious levels went up and you became more infectious. So screening for symptoms might not keep an asymptomatic patient out of the dental environment, and that might increase the risk as well. And certainly, with this thought that we're talking about an airborne virus, and droplet and aerosol procedures were really important, that made us think about increased risk. But some more recent studies have really kind of delved into aerosols, and they've tended to suggest that perhaps aerosols don't pose as much of a risk as we thought, noting that most of the contamination from dental aerosols is actually from the water coolant. So we're still seeing virus particles in the aerosol, but perhaps not at a level that increases infectious risk. Australia reported its first case of SARS-CoV-2 on the 26th of January back in 2020 and in Melbourne, and we experienced a series of waves over the next 2 years. And here you can see just the Victorian experience, the size and the duration of those waves. And you cast your mind back to that first wave in March of 2020, and it almost looks inconsequential now on the chart in terms of the actual numbers. And in fact, in hindsight, what we know is that a large number of those cases were overseas arrivals. It actually wasn't community transmission. But one of the government measures that was imposed to try and reduce the spread of the disease was to impose restrictions on the community. And one of those restrictions was to restrict access to dental care and only allow the provision of urgent and emergency dental care. And as we experienced subsequent waves in Victoria through July, August in 2020, and then some smaller waves, but then certainly the large wave towards the end of 2021, those restrictions kept coming back into play because it was thought that dentistry posed an increased risk of community transmission, having patients out and about, patient to dentist, dentist to patient, and also because essentially the dental care was not seen to be essential by policymakers. So it was easy to make that restriction from their perspective. But not surprisingly, those lockdowns and restrictions have had a significant impact on the provision of dental care. So here we can see dental services provided through the Child Dental Benefits Scheme as a proxy for overall dental practice activity. And this is again part of another evident research project. The dotted green line shows the average number of services. So it's an average of the 2014-15 to 2018 data. I've stretched it out here on an axis from July 2019 to June 2022. So it's sort of a repeating yearly cycle spread out 3 times. The grey shows a standard error and a range around that mean. So you can see that there's a bit of variation that goes on from year to year, and variation related to school holidays in particular. But the orange, if we focus on that, is the dental practice activity that happened from July 2019 through until May 2022 in Victoria. And you can see every time there was a period of restrictions, March, April, May in 2020, July, August, September in 2020, and then July, August, September, October in 2021, a really significant decrease in the amount of dental services that were provided. So concerns about practitioner safety and risk of transmission in the dental setting that drove these restrictions had a really significant impact on the provision of dental care. And we know that this deferral of dental care is going to have a significant impact on oral health outcomes for many patients moving forward. So in this study, we got de-identified data from the Victorian Department of Health primarily as the data source. We also went out to dentists and asked them to participate in the study and volunteer information as well. But most of the data comes from the Victorian Department of Health. Up to 2020, they'd identified 32 cases that were diagnosed in staff working in dental settings. There were 11 dentists, an oral health therapist, 2 prosthetists, 18 dental assistants, and 2 administrative staff. The Department of Health identified that 6 of those were acquired in the dental practice setting, but only 2 of those were from patients, the other 4 from staff members in the practice. 17 of the cases, it was determined that they acquired it from outside of the workplace. So they came to work while they were infectious, but they certainly didn't acquire it at work. And there were 9 cases where they were unable to determine. So they'd worked during that acquisition period, but there wasn't contact with a confirmed case in the workplace. Since then, the department's identified a further 154 cases diagnosed in dental staff, but we don't have further information on those cases yet, where they were working, whether it was acquired in the dental practice setting. So we're still trying to work through those cases with the department. There are 2 other cases that we know of where dentists have provided us with information. One where it's fairly well known that it was acquired from a patient, and one where it's most likely that it was acquired from a patient. So of the 4 cases where we think that it's patient to dentist transmission, only one of those was an aerosol generating procedure was performed. And the others were examination consult type appointments. In all of the cases, dentists were likely to only be wearing a level 2 face mask. A couple of the cases occurred before there were recommendations around P2N95 masks. So it's unlikely that they were wearing P2N95s. There were certainly instances where the dentists weren't wearing a mask at a point in time during contact with the patient, perhaps at the outset of the appointment, or they took the mask off or lowered the mask to talk to the patient during the appointment. And in all of the cases, the patient was asymptomatic. So it points to screening as being effective in keeping out symptomatic patients. But as we've said, patients can be asymptomatic and infectious. So that's not a fail-safe mechanism. There were these 4 cases of suspected staff-to-staff transmission that were effectively revolved around 2 outbreaks of 3 staff each. In both of those instances, a staff member attended work whilst they were infectious, and they subsequently infected other staff members in the practice. And there were periods of time where those staff interacted and they weren't wearing masks. So again, it highlights that it's broader than just what's happening in the dental surgery environment and the patient interaction, and we need to think about risk and safety across the whole workplace. The study's got a number of limitations that we need to bear in mind. So the Department of Health data wasn't collected specifically for the purpose of assessing risk of transmission in the dental practice setting. So it is missing some details. For example, the type of PPE that's worn, the dental procedures, risk mitigation measures, and so on weren't always adequately described. And like I said, we've now got this new data, 154 cases that we're currently trying to analyse. Now, it's possible that all of those 154 cases might be patient to dentist transmission, but I suspect, based on the 32 cases from 2020, where only 2 were patient to dentist and 4 were staff to staff, that we're not likely to see those full 154 resulting in workplace transmission. If they did, we'd still only see a prevalence in dental practitioners slightly higher than what we see across the general population. And if we look at what other research is out there, there was a big seroprevalence study in the UK in the start of 2020 following dentists and receptionists. And there was a much higher rate in dentists than receptionists in May before there was some significant service restrictions. And this was seen as evidence that there was a higher risk for patient-facing dentists because of that higher risk perception. Whereas the receptionists had a rate that was very similar to the general population. And then when dentistry reopened again in June, the rate for dentists dropped down to 11.7, and it was suggested that that was a result of the enhanced protection measures such as PPE changes to help reduce the risk. But it's important to note that this study doesn't provide direct evidence of increased risk because they didn't directly assess the source of exposure. So although there are a lot of dentists who had SARS-CoV-2, they weren't able to definitively say that that was acquired in the dental practice setting. A study in the Buenos Aires Dental Hospital in 2020 found a much lower rate of SARS-CoV-2 across dentists, dental assistants, and non-clinical staff compared to what was happening in the general community. Nearly 3,000 dentists in Germany in 2021, about 6.5% of the dental staff had acquired SARS-CoV-2, which was very similar to the population prevalence at the time. And a study of over 600 dentists in Canada from the end of 2020 to the start of 2021 showed an incidence of 1,084 per 100,000 dentists, which was much lower than the general population incidence of 1,864. So the lessons from this study, they build on the evidence that that suggests that the risk of SARS-CoV-2 transmission via dental procedures is actually lower than perhaps what we initially thought at the commencement of the pandemic. Staff-to-staff transmission remains a risk, and so we do need to be really mindful of that when we think about risk mitigation measures. And those risk mitigation measures have been shown to be very important and effective, at least in the Victorian setting. So respiratory protection, high volume evacuation, rubber dam, pre-procedural mouth rinse, patient screening and ventilation all play an important role. And something to bear in mind with that staff-to-staff transmission is that we need to think about the workplace as a whole and the interactions that happen between staff members and staff members or staff members and patients, not just during treatment, but the entire time that people are in the workplace, because it's aerosol generating behaviors, the breathing, coughing, sneezing, that seem to be as important as what's happening from a treatment perspective. And I think a really important key takeaway from this is that based on this level of risk of transmission, and what we saw happen with restrictions on the access to dental care is that we need to be really careful that we don't restrict dental services on the basis of transmission risk in the future, either with subsequent waves of SARS-CoV-2, and we're seeing really increased numbers at the moment with the new variants of Omicron. But if we do encounter this scenario in the future with different respiratory viruses, that we need to be really careful about not restricting access to dental care, and we need to really reinforce that dental care is absolutely essential. This research couldn't be done without the generous support of the Evident Foundation, which in turn relies on the support of dentists and others in the community. So please think about donating to Evident to help support future research projects like this. And if you're interested in being involved in practice-based research, go to evident.org.au for more information. Thanks.